You know, when you see a kid maybe trip over, not even that hard, but end up with a huge bruise, or perhaps you've heard about someone needing special care before even minor surgery.
Yeah, exactly.
Well, today we're doing a deep dive into hemophilia A.
Mm.
Think of this as your sort of essential guide.
Mm-hmm.
We want to get you up to speed on this genetic bleeding disorder,
Yeah.
hitting the key info you need without, drowning in detail.
That's the plan. We're going to unpack hemophilia A, what it is, the causes, risk factors, how it works in the body, and really importantly, how we tell it apart from other conditions that might look similar.
Right.
The aim is a clear, concise picture, perfect for getting a solid grasp quickly.
Okay, let's jump right in then. What exactly defines hemophilia A?
Well, put simply, hemophilia A is a genetic condition. It basically affects how well your blood can form clots.
Okay.
The core problem is either not enough clotting factor VIII or the factor VIII you have doesn't work properly.
Factor.
Yeah, think of it like a key ingredient in the recipe for a blood clot. If you're short on it or it's faulty, even minor injuries can cause, well, prolonged bleeding, excessive bleeding.
And this is mostly something people are born with, inherited.
Almost always, yes. It's primarily passed down in families. But interestingly, there are these rarer situations where someone can actually acquire hemophilia A later in life.
Acquire it. How?
Usually it's because the body mistakenly starts making autoantibodies that attack its own factor VIII. It's kind of like friendly fire.
Okay.
Sometimes it can also be linked to things like certain blood cancers, what we call hematological malignancies, often in older people.
It's interesting that it can be acquired too. Now, I remember reading hemophilia A isn't like one size fits all. There are different levels of severity.
Absolutely right. The severity really depends entirely on how much functional factor VIII is circulating in the blood.
Okay.
We usually categorize it as severe, moderate, or mild. Severe is when you have less than 1% of normal factor VIII activity.
Less than 1%.
Wow. Yeah, and these individuals often show bleeding problems very early on. Moderate hemophilia is between 1% and 5% activity. Mild is anything over 5%.
And does that affect when it's picked up?
Often, yeah. People with mild hemophilia might not even know they have it until, say, they have major surgery or a significant injury, maybe later in childhood or even as an adult.
Right.
And just going back to the acquired form for a second, the factor VIII levels there can really vary quite a bit, which can sometimes make diagnosis a little trickier.
Okay, so the amount of working factor VIII is key. What's the underlying reason for this shortage? The genetics.
So the root cause is a mutation in the F8 gene. This gene holds the blueprint for making factor VIII.
F8 gene.
And it's located on the X chromosome, specifically in a region called XQ28. If there's a mutation there, the body just can't produce enough working factor VIII, hence the deficiency.
And being on the X chromosome, that's crucial for how it's inherited, isn't it? That X-linked pattern.
Exactly. It follows an X-linked recessive pattern. Think about it. Males have one X and one Y chromosome. If their single X has that faulty F8 gene, they'll have hemophilia A.
Because there's no backup X.
Precisely. Females have two X chromosomes. So for a female to actually have hemophilia A, she'd generally need the mutation on both X chromosomes, which is much rarer.
Right.
More often, a female inheriting one faulty copy becomes a carrier. She usually doesn't have major bleeding issues herself because her other healthy X chromosome compensates.
But she can pass it on.
But she can pass the mutated gene to her children, yes. That's why it predominantly affects males.
So family history must be a massive risk factor then.
It's a primary one. If hemophilia A runs in the family, the risk is significantly higher. As we said, it's typically males affected, females usually carriers.
Okay, we've got the what and the how. Now, fundamentally, what's going wrong inside the body? The pathophysiology.
So the basic problem is that lack of functional factor VIII. The clotting process is like a complex chain reaction, a cascade.
It's dominoes falling.
Exactly like dominoes. Factor VIII is a critical domino in that sequence. It helps activate the next step, which eventually leads to forming a stable fibrin clot.
Okay.
If you don't have enough working factor VIII, that domino doesn't fall correctly or falls too slowly, the whole process gets disrupted.
And the result is?
The result is impaired blood clotting. Bleeding goes on for longer than it should.
Okay. So if someone presents with unusual bleeding, doctors obviously need to consider hemophilia A.
Yeah.
But what else is on their list? What are the key differentials?
Yeah, that's really important. Several other conditions can cause bleeding symptoms. Top of the list would probably be von Willebrand disease. That's another inherited clotting disorder, but involves a different protein,
Right, not factor VIII.
not factor VIII. Then there's hemophilia B, that's a factor IX deficiency. Think of it as a cousin condition.
Okay.
We also need to think about acquired coagulation disorders, maybe from liver disease, or a condition called DIC. Hemophilia C is another possibility, factor XA deficiency, though it's less common.
Still quite a few.
And don't forget things like vitamin K deficiency or if someone's on anticoagulants like warfarin. Plus, issues with fibrinogen or the system that breaks down clots, platelet disorders where the platelets themselves aren't working right, and even problems with the blood vessels themselves being too fragile.
Wow, okay. That's a broad list.
Yeah.
Any tricks for remembering some of those main ones?
How about a slightly silly mnemonic? Very bad acquired cold, very funny platelet vessel.
Okay, let's break that down.
So very for von Willebrand, bad for hemophilia B, acquired cold for acquired coagulation disorders and hemophilia C, very funny, for vitamin K deficiency and fibrinogen fibrinolytic issues, and platelet vessel for, well, platelet and vessel disorders.
Very bad acquired cold. Very funny platelet vessel. Quirky, but might stick. I like it.
Sometimes the silly ones work best.
So Haemophilia A, how common is it really? Are we talking super rare?
It's definitely considered relatively rare, yes. In the UK, the incidence is around 1 in every 5,000 male births.
1 in 5,000 males.
Yeah, and worldwide figures are pretty similar, maybe 1 in 4,000 to 1 in 5,000 live male births.
Okay.
And it's worth remembering it's significantly more common than hemophilia B, about 5 times more common.
5 times. Okay. And the acquired form?
Much, much rarer. Only about 1 to 4 cases per million people per year. Very uncommon.
Right. So important to know about, but not an everyday diagnosis for most clinicians. What are the classic signs and symptoms we should be looking out for? The clinical picture.
Well, it really varies with severity, as we said, but general clues include bleeding that lasts longer than you expect after an injury or surgery, bruising easily and often quite extensively. Spontaneous joint bleeds are a big one, especially in more severe cases, bleeding into joints like knees or elbows without any obvious injury. Frequent nosebleeds that are hard to stop or excessive bleeding from minor cuts are also common signs.
And how do those severity levels translate into specific symptoms? You mentioned mild, moderate, severe.
Right, so someone with mild hemophilia might only run into trouble with significant bleeding after major injury or surgery.
Only major events.
Pretty much. With moderate hemophilia, bleeding might occur after even mild trauma or less complex surgical procedures. Remember, M for moderate, M for minor trauma causing issues.
Okay.
Severe hemophilia is usually the most apparent. These individuals can experience spontaneous bleeding into joints, muscles, even under the skin. In babies with severe hemophilia, there's that risk of intracranial hemorrhage bleeding inside the head, which is obviously a major emergency.
Yeah, that sounds incredibly serious.
Yeah.
What else might point towards severe hemophilia A specifically?
Well, in newborns, you might see prolonged bleeding after routine things like a heel prick test or circumcision if that's performed. The spontaneous joint bleeds are very characteristic. Knees, ankles, and elbows are the usual suspects.
Knees, ankles, elbows.
Yeah, those weight-bearing or high-use joints. Bleeds into muscles can also happen. Less commonly, you might see GI bleeds or bleeding from mucous membranes, like the mouth or nose. Blood in the urine, hematuria, can occur too, but it's variable.
The long-term impact of those bleeds.
That's the real worry with severe disease. Repeated joint bleeds, especially if not treated promptly, can lead to chronic joint damage that's hemophilic arthropathy. It causes pain, stiffness, and eventually joint deformity. You can also get large collections of blood called hematomas, or dangerous bleeds into soft tissues or the retroperitoneal space behind the abdomen.
That sounds tough. Anything specific for moderate cases?
One practical point for moderate hemophilia is that sometimes excessive bleeding might first be noticed after something as simple as having blood taken, a venipuncture.
Okay, so if hemophilia A is suspected, what tests confirm it? What are the investigations?
It really comes down to the lab work. The absolute key test is measuring the factor VIII activity level in the blood. That tells us how well it's functioning.
Activity level. Got it.
We might also measure the factor VIII antigen level. That's the amount of the protein present, functional or not. But the definitive confirmation and understanding the exact genetic cause comes from genetic testing for mutations in that F8 gene.
And for babies born into families with a known history, how early can you test?
If the mother's a known carrier, testing should ideally happen right at birth for a baby boy. You can use cord blood to check the APTT and, crucially, the Factor VIII level.
And for girls?
Well, if the father has hemophilia A, his daughters will be carriers. If the mother is a carrier, her daughters have a 50-50 chance of being carriers themselves. They can be tested, usually looking at Factor VIII levels, maybe Factor IX too, just to be thorough. But genetic testing is really the gold standard for identifying carriers accurately.
Okay. What about a standard clotting screen? What would you expect to see?
This is a really useful pointer. In hemophilia A, the APTT-activated partial thromboplastin time is usually prolonged. It takes longer for the blood to clot in that specific test pathway.
APT is up.
Exactly. But the other common tests, like the prothrombin time, or PT, which gives the INR, bleeding time, and the platelet count, are typically normal.
Any way to remember that?
Maybe think of the A in APTT linking to the A in hemophilia A. That's the one that's affected. It's abnormal, it's raised or prolonged.
APTT links to hemophilia A. Nice one.
Hopefully helpful.
Any other blood tests or imaging that might be involved?
A full blood count, FBC, is usually done to check for anemia if there's been significant bleeding. As we said, PTINR, bleeding time, fibrinogen, von Willebrand factor, those should all be normal in isolated hemophilia A. The confirmation really comes from seeing that reduced Factor VIII activity, often written as Factor VIIIC, the percentage activity dictates the severity.
And imaging.
In an acute situation, like a suspected internal bleed, imaging like a CT scan is vital. If someone has ongoing joint issues, X-rays can show degenerative changes from past bleeds, and MRI or Doppler ultrasound can give a more detailed look at joint damage, the arthropathy.
Okay, diagnosis established. How is hemophilia A managed? What's the core treatment strategy?
The absolute cornerstone of treatment is Factor VIII replacement therapy. It's basically giving the person intravenous infusions of Factor VIII, concentrate to boost their levels and allow their blood to clot effectively.
Okay, replacing what's missing.
Exactly. And this can be done in two main ways. Either prophylactically giving regular infusions to prevent bleeds from happening,
Prophylaxis?
or on demand treating bleeds as they occur.
What about in an emergency? A really bad bleed?
Right. For a life-threatening bleed, the absolute priority is the ABCDE approach: airway, breathing, circulation, disability, exposure, standard emergency procedure. But alongside that, immediate administration of Factor VIII is crucial.
Get the factor in fast.
Absolutely. And these situations nearly always require urgent referral to or discussion with a specialist hemophilia center. Other things might be used too. Tranexamic acid is helpful for stopping bleeding, especially in the mouth, nose, or gut. Pain relief analgesia is important. For mild cases, sometimes a drug called desmopressin can temporarily boost the person's own Factor VIII levels. And physiotherapy plays a huge role in recovery, especially after joint bleeds.
Do the treatment plans differ much based on severity? Mild versus severe?
Yes, definitely. For mild or moderate bleeds, it's usually on-demand Factor VIII, maybe antifibrinolytics like tranexamic acid, and pain relief. Desmopressin might be an option for some mild cases, as mentioned.
And severe?
For severe hemophilia, the standard of care now is generally prophylactic Factor VIII. Regular infusions, maybe 2 or 3 times a week, or sometimes less often with the newer extended half-life products. And then there's the complication of inhibitors, those antibodies against Factor VIII. If someone develops inhibitors, their treatment becomes much more complex and needs expert management, often involving different types of clotting factor products or strategies.
What about advice for patients themselves? Things they can do or should avoid? Non-prescription advice.
Patient education is absolutely vital. Understanding the condition, recognizing bleeds early, knowing when to seek help. That's key.
Makes sense.
They should generally avoid NSAIDs, things like ibuprofen or aspirin, as these can affect platelet function and potentially worsen bleeding.
Avoid NSAIDs.
Yes, and intramuscular injections should also be avoided due to the risk of causing a bleed into the muscle. Subcutaneous injections under the skin are usually much safer.
Okay.
Wearing a medical alert bracelet or carrying identification is really important too, so healthcare providers are aware in an emergency. And physiotherapy, again, is crucial for maintaining joint health and recovering function after a bleed.
So it's a very proactive partnership between the patient and the medical team. What about specific situations like pregnancy?
Managing pregnancy in a carrier or someone with hemophilia A needs a real team approach. Obstetricians, hematologists working together.
Multidisciplinary.
Exactly. Fetal sexing can often be done via blood tests or ultrasound. The delivery plan needs careful consideration, balancing maternal and fetal risks. If the baby is male, there needs to be a plan for immediate testing and potential Factor VIII treatment right after birth.
And how is treatment monitored long-term? How do you know it's working well?
For patients on prophylaxis, there's regular clinical follow-up and lab monitoring. This includes checking Factor VIII levels periodically to ensure they're hitting the target range, and also screening for inhibitor development.
Checking for those antibodies.
Yes. Routine joint imaging isn't typically standard unless there are specific symptoms or concerns. And a big part of monitoring is also assessing adherence, making sure the patient is consistently taking their treatment as prescribed.
With all these treatments, what's the long-term outlook like now for someone with hemophilia A? The prognosis.
Honestly, the prognosis has improved dramatically. With proper management, especially consistent factor replacement therapy, people can live much longer, healthier lives than in the past.
That's great news.
It really is. The key remains regular monitoring and sticking closely to the treatment plan. That's the best way to prevent complications and maintain a good quality of life.
Can hemophilia A itself be prevented? Or can the complications be prevented?
Well, we can't prevent the genetic mutation itself, but genetic screening is available for families with a known history, which allows for informed decisions about family planning.
Genetic counseling.
Precisely. Preventing complications is really about that patient education, avoiding risky activities, recognizing bleeds early, getting prompt treatment, and that medical alert ID we mentioned is a simple but potentially life-saving preventative measure in an emergency.
Finally, despite the advances, what are the main complications that can still occur?
Joint damage. Hemophilic arthropathy from recurrent bleeds remains a major concern, although prophylaxis helps reduce this significantly.
And joint damage.
Yes. Inhibitor development is probably the most significant treatment complication today, affecting a substantial minority, maybe 25–30% of severe cases. It makes treatment much harder.
Inhibitors, okay.
Life-threatening hemorrhage, while less common, is still a risk. And historically, there was the risk of infections like HIV and hepatitis from older factor products, though modern treatments are much safer due to rigorous screening and processing methods.
Safer products now.
Definitely. For those with persistent inhibitors, there's a specialized treatment called immune tolerance induction, ITI, which tries to retrain the immune system. Sometimes bleeds just don't respond well, needing alternative therapies. And rarely, in acquired hemophilia, immunosuppression might be tried.
Okay, wow. That covers a huge amount of ground on hemophilia A. So just to quickly recap the absolute essentials for everyone listening. Hemophilia A is genetic, caused by deficient or defective Factor VIII, leading to clotting problems and prolonged bleeding.
Yep.
Severity varies, impacting when and how symptoms appear. The main treatment is replacing that Factor VIII, either to prevent bleeds or treat them when they happen.
Exactly. Prophylaxis versus on-demand.
And early diagnosis, consistent treatment, and managing potential complications like joint damage and inhibitors are absolutely key for a good long-term outcome.
You've nailed the core points. That's the essential insight.
So thinking about all the progress that's been made, especially in treatment, what do you see as the biggest ongoing challenges for individuals living with hemophilia A and their families today?
That's a great question. I think equitable access is still a major challenge globally. Ensuring everyone who needs it gets access to safe, effective factor concentrates and comprehensive care regardless of where they live, that's huge.
Access to care.
Yeah. And managing inhibitors effectively when they do develop remains a significant hurdle. It's complex, expensive, and not always successful. And beyond the purely medical, the psychosocial impact, living with a chronic condition, the need for constant vigilance, managing infusions, the potential pain and limitation from joint damage that takes a toll on individuals and families, we shouldn't underestimate that.
Really important considerations.
Yeah.
Well, if you listening want to dive deeper into hemophilia A or frankly any other medical topic for revision or just general knowledge, we absolutely recommend checking out passthemsgro.com.
And also freemsra.com. Both are fantastic resources, really high yield stuff, great for learning.
Definitely check them out. Thanks so much for tuning into this deep dive with us.